Welcome to the Pathways Research and Training Center's March 22nd webinar, Multisystemic Therapy for Emerging Adults, MST-EA, Treating Young Adults Who Have Justice Involvement and Behavioral Health Conditions. I'm John Osowski, Director of Dissemination for Pathways, and I'd like to begin with a few housekeeping announcements. Please see the advice on this slide to make the most of your GoToMeeting experience. In particular, please note that during the presentation, all audience members will be muted, but you can send your questions to us via the chat feature. We'll get to everyone's questions at the end, and if we can't answer your question on this webinar, we'll make sure that we can email an answer to you. A recording of this webinar will also be made available online shortly after the webinar ends and will be available from the link you see below. At this time, we'd also like to invite everyone who registered for this webinar to stay in touch with Pathways RTC by signing up for our monthly RTC updates. We feature links to Pathways resources like this webinar, as well as news and events of interest to the field. You'll receive an invitation via email after the webinar, and we hope that you will accept it. This webinar was made possible through funding from SAMHSA, the Substance Abuse and Mental Health Services Administration, and NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research. And with that, I would like to welcome you all to today's webinar, Multisystemic Therapy for Emerging Adults, MST-EA, treating young adults who have justice involvement and behavioral health conditions. Our panelists today will be Maryann Davis, Research Associate Professor of Psychiatry, Director of Systems and Psychosocial Advances Research Center, and Director of the Learning and Working During the Transition to Adulthood Rehabilitation Research and Training Center at the University of Massachusetts. Maryann, if you just say hi to our audience, please.
Hello, audience.
We also have Ashli Sheidow with us, a Senior Research Scientist and Clinical Psychologist with the Oregon Social Learning Center. With her colleague, Dr. Mike McCart, she has developed MST-EA and studies treatments for mental health and substance abuse problems in adolescents and emerging adults, particularly those who have co-occurring problems. Ashli, if you'd say hi to our audience today.
Hi, everyone. Thanks for having us today.
Yeah. And I'm sure Ashli and Maryann will say more about their work in a moment, but I also wanted to just take a moment to say that I'm pleased that both of our presenters are featured in our upcoming edition of Focal Point, which this year is dedicated to justice and recovery. From the link on this slide, you can subscribe to our print mailing list, and you can even download past editions. Before we move on, we'd like to know a little bit more about you, our audience. So we're going to just have a very quick poll. I'm going to launch that right now. And if you would just pick from one of the options that's on your screen, just telling us a little bit about your role and what has brought you to this webinar. So please choose between evaluator or researcher, service provider or manager, family member or advocate, policymaker, or if you're a young adult with lived experience, we'd like to know if you're on with us today too. And we'll give about 5 or 10 more seconds for voting. We've got about 80% have voted already. Great, and with 85% of people voted, we are going to close the poll. And then I'd like to share the results with you. And it looks like that most folks that are on today are service providers or managers of agencies that provide services. So thank you very much for attending, and also to our evaluators and researchers. And we can't forget our family members and advocates and policymakers, and certainly we welcome our young adults with lived experience. We really appreciate you joining us today. And with that, I'm going to turn things over to Maryann and Ashli.
Thank you, John. This is Maryann. I'm going to start, and I'm going to give you a quick overview. We'll be talking about essentially why we have chosen to develop multisystemic therapy for emerging adults. We've referred to it as MST for short, so give a little bit of background information about that. And then we're going to describe the adaptation of multisystemic therapy that we did to create MST. and some of the details of the different components of that. And then we're going to present some of our initial findings from our feasibility research that we did. And then we're going to talk a little bit about 2 large clinical trials that are just getting underway to test the model more rigorously. So we want to start off with thanking our funders, which include the National Institute of Mental Health and the National Institute on Disability and Rehabilitation Research, and the Substance Abuse and Mental Health Services Administration. Many of you will recognize that the National Institute on Disability and Rehabilitation Research is now the National Institute on Disability, Independent Living, and Rehabilitation Research. We also thank our collaborators. This kind of a project has a lot of collaborators involved. It's very much a team effort. And so Ashli already described briefly Mike MacArthur, who is her colleague at Oregon Social Learning Center. We have wonderful colleagues and partners in the Connecticut Department of Children and Families, Sarah Laurie, Terry Foley, and Ann McIntyre-Warner. This research takes place in Connecticut, and the intervention itself was funded by the Department of Children and Families in Connecticut. We also have senior consultants on the project for the research, including Chuck Lids from here at UMass Medical School, Ed Mulvey from the University of Pittsburgh, Mary Evans down at the University of South Florida, and Scott Hengler at the University of South Carolina, Medical University of South Carolina. And finally, we want to thank our MST team that is offered by the North American Family Institute. They refer to it locally as the TAY team. If any of you are from Connecticut, you might recognize them as the TAY team there. And in particular, our emerging adult participants and their social network members. We are very grateful to them. Next slide, please. So we started on this path to developing MST after conducting some research in Massachusetts, where we looked at the overlap of individuals who had received intensive mental health services through the Department of Mental Health as adolescents and examined their arrest rate in Massachusetts. And if you can show the next 2 lines, there we go. So if we look at all of the males in that cohort, you can see that there was a peak age of arrest at around age 18 and declining slowly into young adulthood. And for all females in that cohort, there was sort of a chronic arrest rate around 10%, which is actually very elevated for females. If you'll show the next 2 lines, these lines are highly elevated. And we wanted to understand who were individuals within this general population of individuals who had received adolescent mental health services that might be at particularly high risk for arrest and involvement in the justice system that we might be able to target so that we could either prevent their involvement or reduce the likelihood of them being involved further. And what we found was the solid brown line represents males in this cohort who had been arrested the previous year and females who had been arrested the previous year. And you can see that their risk for arrest in the subsequent year for females was between 30 and 40%, and for males hovered around 50%. This is a very high risk group for arrest. And so seeing this and thinking about this population and the detrimental effects of being arrested during the transition to adulthood, we wanted to identify an intervention that we might be able to apply to reduce that involvement in the justice system, and realized there were a variety of evidence-based practices that have been used to reduce juvenile delinquency and juvenile recidivism that can be applied to individuals up to the age of 17. But when we looked in the literature, we found that there were no interventions for those who are 18 or further into young adulthood, and as you can see that those arrest rates are very high for this population. Next slide, please. So in thinking about what kind of an intervention we might be able to develop to address this population's need to reduce their involvement in the justice system, and because there were no interventions geared specifically for transition age youth or young adults, we wanted to understand and see what was in the literature about what were the malleable causes, things that can be changed, of offending and then desistance in the general population. You can see on the left that there's a fairly robust list of factors in juveniles that have been identified in a very rich literature on juvenile delinquency. So the involvement with antisocial peers, the reduction in parental supervision or monitoring, having lots of unstructured time, which would be either not being in school or unstructured time after school, involvement with substance use. There's a rational choice or distorted cognitions that are involved. And one of the things that has led to desistance is being attached to school, pro-social peers, and family. And then when we look in the adult literature, what we find is that thinking about what's in the adult literature in terms of what we know about juveniles and transition age youth being somewhat in between developmentally, so we found that there is less influence of peers, although not entirely gone. The parental influence is lessened and typically more indirect. That we see that there's still an effect of unstructured time, but now it tends to refer to not being engaged in work. One of the constant themes in both age groups is the involvement of substance use, rational choice and distorted cognitions, and now the attachment to institutions of informal social control is one way to think about school, pro-social peers, and family in juveniles, is that the attachment to work and spouse has been found to help adults desist from criminal behavior. Next, please. And if you'll continue down to the bottom. Thank you. And so we felt that an intervention for older adolescents and young adults or transition age youth should, taking both of these age groups into consideration, we still need to target peer influences. We want to target parental support for positive change and reduce negative parental influence. We want to make sure that we're targeting engagement in school and or work, that we also clearly want to target substance use, cognitions, and we want to strengthen support and attachment to positive social network members. Next slide, please. Now, those were findings for the general population. When we looked at the literature to see what did we understand about individuals who'd been offenders who had mental illness, we wanted to make sure we understood whether there were different causal factors. And essentially, there have not been identification of different causal factors. We understand it a little bit less in those who have mental illness. One of the things that has been very well demonstrated is that simply addressing mental health needs does not reduce offending behavior in adults. And so that is a distinctive finding for the thinking about how to help young adults who have mental illness who are in trouble with the justice system. However, while reducing mental health symptoms doesn't directly reduce offending behavior, we know that mental health does influence those other targets of being engaged with social network members or one's success in school or work. And so an intervention for this population clearly needs to target mental health symptoms and other co-occurring issues. Next slide, please.
And so I think we're going to do a poll at this point. Is that possible, or did we get that in there?
No, we didn't have a second poll today. I'm sorry.
Okay. So we're going to transition now to talking a little bit about standard MST and also MST and the adaptation of standard MST. So as John said, I'm the co-developer of MST with my colleague and friend Mike McCart. Up until about 3 years ago, we were faculty at Medical University of South Carolina, where we got the chance to start working with Maryann. We had been collaborators working with Scott Hengler, who was the developer of standard MST. And we started working on adapting it and then testing it for this high-risk emerging adults in general. So to date, there are no treatments specifically for emerging adults that have reached evidence-based status, and whether that's for serious conduct problems, mental illness, substance abuse, or multiple comorbid problems. But when we look, as Maryann said, with multi-problem youth, The evidence-based practice that has the most clinical trials and has shown the longest sustained outcomes is MST. It's a family-based treatment used for a variety of high-risk adolescents. It has more randomized trials than other adolescent treatments, than any other adolescent treatment, and also has sustained outcomes, showing outcomes more than 20 years beyond treatment. And so that's kind of the, why MST is a particularly, one of the reasons why MST would be a particularly well suited to do an adaptation for another high-risk age group. So standard MST, these are kind of hitting some of the high points. So it's geared towards adolescents who are 12 to 17 years old who don't have a mental illness. It is an intensive home-based treatment. A team is made up of, MST team is made up of 3 to 4 therapists who work with a supervisor who is on site. Each therapist carries 4 to 6 families each. And their goal is promoting behavioral change primarily by empowering the caregivers and the parents. The adult caregivers are parents and legal guardians of a teenager. The individualized interventions they use, what they're doing is trying to target that comprehensive set of risk factors. Those are those factors for desistance and recovery that Maryann summarized on her slide. So the individual factors, family, peer, school, and neighborhood factors that would reduce delinquency and also sustain long-term reductions in recidivism. Primarily the interventions that are integrated into the MST model come from empirically based clinical techniques, a lot of CBT strategies, behavioral therapies, some strategic and structural family therapies, strategies from those. And a typical duration is 3 to 5 months. And so that's kind of standard MST in a nutshell. Obviously there's a lot more detail. And I'm very happy to, if my contact information is at the end of the presentation, I'm happy to talk with folks more about standard MST as well as the specifics of MST, and I'll provide you there's also a article that summarizes a case, a clinical case. I know a lot of you are from the clinical world, and we do have one article that summarizes a case example, and I can email PDFs of that to anyone who's interested with more detail. So we go to the next slide. This is a little bit of a mirror. So these are those same 6 points, and what we're going to do is go through each of these, and so I can describe kind of the major points of adaptations for MST. So MST, we were particularly wanting to focus on the justice-involved young adults, but in particular those who did have a mental illness. Whereas a serious mental illness is often too severe, it can't be managed within an MST team. It's in some cases a rule out for standard MST. When we were developing this for MST, we had that research that Maryann had done as a foundation of knowing that that's a group that is particularly in need for an intervention to prevent recidivism, and so that's why we went kind of at that group rather than having it as a rule out. So that's one key difference, is the age group and then the mental illness. It is an intensive home-based treatment like standard MST is, and in particular, just a few things about that is that while MST requires a parent or adult caregiver, emerging adults that we're working with can be living on their own, they can be with family or friends, they can be in foster care, they can be in supportive housing or community-based group homes. They also can have children of their own. And so it's kind of a variety. So home-based for us is a variety of different locations. And there is a 24/7, just like standard MST, there's a 24/7 on-call availability. So treatment is kind of this intensive, but home-based for us is a little bit larger net than standard MST. The second point there is that treatment, there is a low caseload. With our group, it's still a team of 3 to 4 therapists working with a supervisor. We also have coaches that are paraprofessional coaches that are part of the model, and we'll talk a little bit more about that during the presentation. And the caseload is a little bit lower, so each therapist maxes out at 4 cases. The team, I want to mention, does coordinate with psychiatrists or nurse practitioners in the community for medication management, but these are not members of the team. That's actually a change from the initial design, and coming from our years of experience. We've had 8 years of experience now delivering this model, and when we initially started it, we had designed it with a psychiatrist attached to the team, and that's actually a shift that we've made over time, is to engage with practitioners that are in the community, rather than having one that's set aside for our team. The third point there is just like standard MST, the therapists meet clients whenever and wherever they're comfortable, but with us the primary contact is with the emerging adult. We do meet with social network members, and for us the social network member can include family, but it can also include other key people like peers, partners, other people that are important to the young adult. So we do meet with them when needed, but in each of those interactions, we're trying to put the emerging adult in the driver's seat. So we're really trying to empower the young adult to be in control of those meetings and those interactions, rather than with standard MST, the therapist does a lot of one-on-one meetings with the parent, because that's our key lever for change. So that's a pretty big departure for this adaptation. The fourth one, like standard MST, we have this ecological way of working, but for us, the work component gets added, and that becomes a key piece of what we do. So a really strong career focus that you wouldn't typically see in a standard MST program. And then like standard MST, we intervene on the justice involvement, but also the mental illness. Our clients often have also significant trauma, substance abuse, and other significant problems. So we're using interventions that are empirically based for emerging adults for those particular problems. So there's a heavy reliance on CBT, cognitive behavioral therapy, CBT, as well as behavioral and strategies. And then we also use a lot of motivational interviewing techniques. But in all of these, we're really emphasizing long-term, sustainable successes in recovery. We want to lead to permanent independence of the emerging adults. And so whereas instead of having a parent deliver a behavior plan like you would in standard MST, we really want to have strategies that are in place that are going to be a longer term into adulthood to help them successfully transition into adulthood. And then lastly, the sixth point is our treatment duration is a wider range, so lasting anywhere from 4 but even up to 12 months. Plus there's an option of a couple of additional months working with the MST coach for 2 to 4 months beyond that. So we can go to the next slide.
Ashli, just before we move on from this, we did get a question about if there was a site out there on the web where folks could get more detailed information on MST.
Yeah, there is a site that's attached to the MST Services website, and so they have they list each of the adaptations of MST, and there's kind of a nutshell version there. So there's some information there, and then the other place would be, the other option would be that I can send the case example paper that could give more kind of nitty-gritty details of the model.
Great. So we'll archive that paper, or at least a link to it, with these slides and the recording, and then maybe with our follow-up email to everybody, we can just send that link as well. So that
yeah, it's just dawning on me. I think you put the link to the MST Services website that talks about emerging adult, the adaptation. I think you put that in the article as well, in the focal point article that you wrote.
Yes, exactly. So please look out for focal point as well. All right. Thanks, Ashli. I'll return us to our regularly scheduled program.
So our overall goals, again, are it's a little bit broader than with standard MST. We're going after the recidivism, but we're also, the team is providing direct treatment for mental illness to try to reduce the mental illness symptoms. And for us, the types of disorders, the types of symptoms range anything from anxiety symptoms and kind of generalized anxiety or phobic disorders, to mood disorders and bipolar disorders and those symptoms that go along with that, all the way to in PTSD, trauma-related symptoms, as well as psychotic disorders, so things like schizophrenia and other psychotic symptoms. So kind of the full range of mental illness symptoms that the team is trained to target. Substance use, although with the research we've done so far, every case has had a mental illness, a diagnosis. When they came in, about 70 to 80% of them also had substance use that needed treatment. And so the team is also trained to treat substance use as well. And some of our more recent research is heading in the direction of testing specifically for a population that has justice involvement and a substance use disorder versus just the mental illness symptoms. And then interpersonal conflict is one of the big kind of biggie goals that we go after. And then we have these other things that we know lead to desistance and recovery and long-term success. And so these relate to those factors that Maryann was summarizing. Educational and vocational achievement are something we directly target. Social network and family functioning, making that work more effectively for the young adult. Physical health care is something that has come up surprisingly for us, and so a lot of chronic conditions or untreated health problems that the therapist will work with a young adult to get care for. And then independent living skills and kind of what it takes to successfully transition to adult success. So those are kind of the key factors that we are working on. So at this point, I'm going to tell you some about MST, but again, I do want to mention there's the reference for the paper at the end of this that really goes into a lot more detail. It is somewhat of a complex model, and so this is just giving you a little bit of a taste. And I don't want anybody to feel like they can't get more detail if they are interested in it. So next slide. So how do we go about reaching those goals for those primary referral reasons, and then the other factors that we're trying to target for long-term success and recovery? The way we do that is one aspect is that we're intensively focusing on safety, and this is based on the high risk that we know for this population, that the high risk that they present with across domains. This is the age group where just in the general population, this age group has the highest rates of suicidality, the highest rates of homicidality, and the highest rates of violent victimization. So that presents a lot of safety risk for the young adult as well as their social network. And so that's one of the things we work with first, is to help the young adult find ways to keep themselves safe and have ways to manage that. And then as we go through treatment, working on how they can keep some of those things going long term so that they aren't so reliant on a therapist to help them to maintain safety. We're leveraging and developing the emerging adult social network, and as I said, our goal there is to help that network be more effective for the young adult. We do a process called a social network analysis, and we map their social network, and the way we frame that is that this is your family of choice. So rather than a family therapy where we're focused on the members in your family, with MST, what we're talking about is your family of choice that you're going to have into adulthood, and building that and helping that family to work more effectively for you. We're identifying the values of the emerging adult. We use a values mapping protocol. It comes out of the motivational interviewing world, and so we identify the young adult's values, and then we frame the rest of our work with the young adult around those prioritized values. And so that's where and for those of you who are clinicians, I encourage you to, if you're working with young adults or adults period, I encourage you to take a look at motivational interviewing training that's on this values mapping procedure. It's a card sort protocol that you can learn more about and can be very useful for engagement. So that's a tool that we train therapists to do with each of the clients at the beginning of treatment. And then we're also identifying, as part of that, individual and community strengths. So things like culture and religion and race and ethnicity and other identity factors. And we're helping the therapist to view those as strengths of an emerging adult that can be leveraged in treatment. And so that's kind of the approach that we take to identifying some of those identity factors and building those as strengths that the emerging adult can see those as strengths that they can leverage in their adulthood. We target housing and independent living skills. It's in a highly individualized fashion. Some folks are going to have housing opportunities available for them and their family. Some folks are not going to have any family members involved. Some folks are going to be aging out of foster care and have some resources or not have resources depending on where they were in the foster care system. And so kind of identifying on an individual basis what the housing needs are and the independent living needs skills needs are for an individual. We target career goals, so this is both education and vocation, again highly individualized, really based on the goals and values and desires of the young adult. Where the therapists are treating the mental illness and antisocial behavior, again a lot of CBT interventions. The most common things are things like cognitive restructuring and affect education. Behavioral activation is a tool that, again, for clinicians in the audience, behavioral activation is a fairly simple protocol to deliver, and we find that young adults seem to really enjoy it and appreciate participating in it. And so that's one that I would encourage folks to take a look at if you're a clinician. We also do a lot of exposure therapy and response prevention for things around anxiety symptoms, anger management skills, things like that. And then we use evidence-based substance abuse and trauma-informed interventions. Motivational interviewing and contingency management are the tools we primarily use for substance abuse. And with PTSD, we use exposure-based interventions. And then coordinating medical and psychiatric care, working on their relationship, improving relationship skills, and then as needed, teaching parenting, a parenting curriculum and improving parenting skills. Next slide. So I want to talk a little bit about the coach piece of the model because I think, folks, this is one real departure. So if you know standard MST, this will be a feature that you're unfamiliar with. So it's one of the major differences. It's a layperson coach that supports the client in individualized practicing of the new skills and activities that we're working on as part of therapy. So these are paraprofessionals who, at a minimum, have completed a high school degree or GED or equivalent, and have a history of kind of success in adulthood, and defined as either they've been employed post high school degree or equivalent, or they're in higher education programming currently. So kind of they've moved into that next phase of young adulthood. So that's kind of the minimum. We have a wide range. A lot of the coaches we have are young adults who are and it doesn't have to be a young adult, but it just tends to attract that because it's an hourly position. A lot of them have been people who are young professionals that have started a job, started their career, but they enjoy the idea of sort of a mentoring type of relationship, but also making a little money on the side in the evenings and weekends, so that's often what it is. Sometimes it's college students or individuals who are in clinical training programs, and while this isn't a clinical position per se, it does expose them to a clinical population that they may not be getting through their program. So those are kind of tends to be who the coach ends up being. Like the rest of MST, coaching occurs in the client's homes and communities, so this is field-based mentoring. They engage the client in recreation and enjoyable activities during, and then during those activities, they're modeling problem-solving skills, relationship skills. So they do that on a weekly basis where there's an activity component to it. And then in addition, in a separate session each week, they're delivering transition age youth skill curriculum. And that covers a wide range of domains that will, I think I've got a slide on that as well. So they kind of function in general as a positive mentor, but also engaging the young adult in pro-social skill building activities and delivering directly curriculum around some skill sets in an individualized way. Next slide. So this gives you an idea of the curriculum. So these are the skill menus and the domains that can be covered. We have these broken out into a standard set of domains and vocational domains. And again, this is delivered based on the client's needs and desires. So it's not that every young adult is going to receive every one of these domains. It's going to be on an as-needed basis. And in large part driven by what their current needs are, but also what their values are, what we've learned from them during that values mapping exercise of what they want to prioritize. So that's often kind of the way we go about making decisions on what to prioritize. We have these domains, and then each domain is broken down into subdomains and sessions within those subdomains. So this is just kind of the upper level of summary. During treatment, our goal is to cover every one of the vocational domains. We find, and the vocational domains as include like the career exploration, things like practicing interviews, some of the soft skills is one of the terms that's used for some of these, the soft skills around vocational searches and maintaining jobs. Things around job searching and applying, but also skills for maintaining a job. So things like, you know, how to interact with different people that you're working with, how to handle situations that come up in jobs. So that's kind of our goal is to cover as much of that as possible. So that's kind of a high priority, just given that we know that that can lead to better desistance and recovery. And then within the standard coach domains, it covers wide things. They'll do things like meal planning and preparation, tracking down a birth certificate, getting a driver's license, banking skills, doing laundry, figuring out bus routes and trying them out, time management, kind of a wide variety of things based on what the young adult's needs are. Let's see. Oh, and I do want to mention that some of the materials that we use are things that we created, but some of them we pulled from existing resources that are available. And so I wanted to mention those. There's Preparing Adolescence for Young Adulthood, and there's some downloads for that on a website called itsmymove.org. Again, itsmymove.org. So there are some materials there. And then also the Transitions RTC that Maryann runs has created more recent materials on some of those topics, and I know those are free downloads. So some of the materials that we use are things that are freely available to folks. So we can go to the next slide.
And Ashley, before we go on to the next slide, I just wanted to mention we've gotten a couple of questions about where MST-EA has been used and is it available in my state. And I think it might be helpful to just remind folks that it was a trial in Connecticut. Is that correct?
Yeah. So the study, Maryann's going to talk about the research we've done, and it was conducted in Connecticut. And then after that initial research was over, the Department of Children and Families in Connecticut wanted to continue the program. So the program has existed in Connecticut since 2008, I believe. And so the program there, there are two teams currently, one that covers Hartford and a couple of areas around Hartford, and one in New Haven and covers a couple of areas around New Haven. There's a program that's getting ready to start up in Baltimore. It will cover Baltimore City as well as Baltimore County in Maryland. And there's a program getting started up in Memphis in Tennessee. And there are a couple of others that are in kind of the early stages of possibilities. And then we also have a program that's over in Australia in Sydney as well.
Okay, thank you.
I'll turn it to Maryann. Okay, so as Ashley alluded to, this team, our program has been evaluated, excuse me, with the initial model and some of the feasibility issues that we wanted to investigate to see, test out a couple of different options in the way that the program was offered so that we could go forth in the research with the best model possible. And so thus far we have studied a population of 17 to 20-year-olds all of whom were screened for having a serious mental health condition. These have included mood anxiety and or psychotic disorders. Many, as Ashli said, also have a substance use condition, and many have had exposure to trauma, even if it hasn't resulted in a diagnosis of post-traumatic stress disorder. They've all had recent arrest or release from incarceration within the past 18 months, and they're all living in a stable community residence at the time of being admitted to the program. Next slide, please. So to give you a flavor of the demographics of the population that will be collected data on, the total N in the first two studies that we conducted were 48. You can see that they were predominantly male, a fair distribution in race. There was also about a 20% of the population or the sample were Hispanic. Most of the individuals who've been referred to the program were 17 or 18-year-olds, where we've had just a few 19 and 20-year-olds. Next slide, please. And you can see there's quite a distribution in their highest level of education attained, where the vast majority have not either received their high school diploma or a GED. So completion of high school is still something that has not yet been attained. And I think a little bit of a surprise to us was the very high proportion who were living at home with their family, but also this includes essentially non-institutional living. So 85% were either living with their family, on their own, or with peers, and then a small proportion of those at the time of being recruited for the research were living either in a treatment facility or in detention, and were about to be released from detention. Having had any employment in the past also had been an experience of the majority of the participants. And just to give you a flavor of who's referring to the team and to the research, adult probation was the most common referral source, with over half of the individuals coming from that referral. The juvenile justice referrals were also a large proportion, and then child welfare was the other large proportion. We also, when we looked at their histories, even if the referral source was primarily, say, adult probation, the vast majority of these individuals had been served by the Department of Children and Families, and thus sort of bolstered their rationale for funding this intervention. Next slide, please. And as you can see, that this population has had quite a significant history. More than half of them have experienced psychiatric hospitalization. 60% of them, a little over, have been in juvenile detention. Over a third of them have been in jail or prison, with also significant portions having experienced homelessness or having been hospitalized for a substance abuse condition. Next slide, please. The study that we have conducted has consisted of two separate studies. The initial was to look at some of the early feasibility work to figure out how do we offer this model, how do we train the therapists, how do we train the coaches, how do we provide supervision, exactly what's going to work with this population, as well as trying to figure out what's going to work in terms of recruiting and retaining them in research as well. Both of the studies that we've conducted have been open trials, meaning that anybody referred to the research was then served by the MST teams. So the research retention for this population, we actually were very pleased to have remarkable success with. These are individuals, even though many of them were in stable community residence at the beginning of the study, by the time we were following them, sometimes at 16 months after baseline, we're living in a wide variety of circumstances. So to have completed 90% of the post-treatment interviews, we were very pleased with. The reasons for missing their post-treatment interview were primarily that two could not be located. One formally withdrew, saying, I'm done with research, I don't want to do anymore. And we actually had two who completed the last interview, but the treatment had not been completed yet, so they did not have a post-treatment interview. And overall, 91% of all interviews were completed, which we were also very pleased to have developed methods that were that successful. Next slide, please. We also found that the MST approach was very successful in attracting young people to complete their treatment. And so we had 52% had completed their treatment, which meant that they had met their goals and they were judged to be sustainable, which is very important. There were also 15% in which there was a mutual agreement between the therapist and the emerging adults that they had gone as far as they were going to go together in treatment, and so treatment ended by mutual agreement. We had only lost engagement in 19% of the sample. And again, putting the high-risk nature of this population, the challenges that they're facing in their lives, we feel like that 19% loss to engagement is actually remarkable success for any intervention. We also, because MST is a community-based, home-based intervention, if an individual enters restrictive placement for a substantial period of time, we can't continue our work, and so we had 10% of the sample ended treatment because of being placed in a restrictive placement, and then 4% moved out of the geographic area that the team could serve. Next slide, please. So we wanted to be sure that we were able to train the therapists up to fidelity, so that they were delivering the treatment as it was intended, and that they were able to do that over time. And in MST, this is achieved primarily by having the young person rate the behaviors of the therapist in a variety of areas so that we could determine whether they were practicing doing their clinical practice in a way that was consistent with a model. And generally, in these different areas, you can see that essentially one would be saying that their therapist never practiced that particular behavior or never achieved that particular activity, to 4 being always. And for all of the therapists, these are the averages across the clients that they served. You can see that primarily they were mostly to approaching always, practicing the activities that would help a young person feel that they were working in partnership, that the clarity of the work was very high. Where therapists maybe had more struggles was in always engaging a young person's social context. And then in the main elements that were sort of the pieces that any MST therapist should be doing, although translated to this age group, there was also very strong fidelity. Next slide, please. We also wanted to make sure that we could examine the work that the coaches were doing. And for the second study that we conducted, we actually were very interested in determining whether the coach should be the primary agent of helping them with their vocational goals, or as you're developing an intervention and you want to make sure that you're not being overly redundant with what already exists in the system, we felt that another possible approach would be for the coaches to not work on vocational goals directly with a young person, but because these are young people with a psychiatric disability, that we would refer them to the State Vocational Rehabilitation Agency, who has a vast resource available to them and networks of employers with whom they have relationships. And so we actually did a small randomized control trial of all individuals within MST to randomize them to either receiving a coach who had the vocational curriculum that Ashli described in the earlier slide, or to a coach who had only the standard curriculum that they could offer, but then the young person was also referred to and facilitated in their contact with the State Vocational Rehabilitation Agency. The vocational coaches offered both curriculum, both their vocational curriculum and the standard curriculum. And this we wanted to test to be sure that we had differences in our coaches. The blue coaches are the standard coaches and the purple coaches are the vocational coaches. And if we look at the standard skills that were offered, we actually found the comparison between the vocational and the standard coaches actually ended up with the vocational coaches having offering more skills on a monthly basis than the standard coaches did overall, although that isn't as blatantly obvious from the bars here, but the number of assessments that we did essentially resulted in the vocational coaches addressing more standard skills. I'm sorry, my monitor just went out, so I'm going to log back on. Okay, there we go. And where we were hoping to see some marked differences was in the number of employment skills that were covered. And what we saw was with both of our vocational coaches, every 2 weeks they were averaging around 2 vocational skills or employment skills per 2-week period, where the one standard coach who had 33 participants or 33 assessments didn't address any employment skills, and the second coach occasionally addressed an employment skill. So good on fidelity, clearly not completely perfect, but we did seem to have coaches in the vocational coaching condition that were addressing employment skills and career skills. Next slide, please.
Maryann, before we go to the next slide, there were just a number of questions about this slide, and I think maybe they could just be cleared up by discussing the difference between the vocational coach and standard coach.
Yes. So the vocational coach and the standard coach are exactly the same, with the exception that the vocational coach also has a vocational curriculum that they cover in their work with the young person, where the standard coach does not. So the standard coach, these are individuals who didn't have access to that vocational curriculum, but the therapist then worked with the young person to connect them to the State Vocational Rehabilitation Agency. Does that clarify?
I think so. Yes, hopefully it did. If not, we'll get to that at the end too. Thank you.
Absolutely. Okay, so for the main outcome that we were interested in, we did find a significant pre-post comparison difference in the number of charges that an individual had been charged with. So there was a significant reduction in the number of charges. And you can also see that the proportion of those who had been arrested in the 6 months prior to the start of treatment was considerably higher than those who were arrested in the 6 months after treatment. Next slide, please. We also had positive findings in other outcomes. There was a significant reduction in the number of mental health symptoms. There was a significant reduction in the amount of peer delinquency. This is the delinquency among the peers of the emerging adults in MST treatment. And while those two were significantly different, out-of-home treatment and incarceration rates were in the right direction. They didn't reach statistical significance. Next slide, please. We also, as Ashli mentioned, that the majority of cases present in need of some substance-related treatment because of their substance-related problems. And we did see a reduction in substance use reflected in their positive urine screens going down in their rate. We didn't see an elimination, but we did see a significant reduction. This was primarily from THC use, where you can see that 21 were positive for THC use, 3 for opiate, and 1 for cocaine. So the substance that these young people were primarily using is THC. And there was a tremendous reduction in that use. Next slide, please. And then when we looked at the vocational outcomes, where we compared those who were receiving vocational coaching versus those who received the standard coaching plus vocational rehabilitation services, we saw a significant increase in positive engagement in those receiving the vocational coaches. So let me describe for you that these smiling but red faces represent individuals who were neither working nor in school. And those who have green or tan faces are those who are either working and in school, working only, or in school only. And at baseline, the two groups were not different, and generally those who were, let's say, red-faced versus those who were not red-faced. If we go to the next illustration, we can see that the post outcomes were different in the two groups. So if you look at the upper group, the number of individuals with red faces was very low during the post-treatment period, whereas if you look at the number of red faces in the those who received standard coaching plus vocational rehabilitation services, a significantly higher group of individuals proportion were not working nor in school, and that was a significant difference. So we ended up concluding that we are better able to help them with their vocational goals by providing vocational coaching rather than not allowing the coaches to have a vocational curriculum, but rather referring them to vocational rehabilitation services. So the model that we are going forth with, everybody will be having a coach that has a vocational capacity and emphasizes vocational support. Next slide, please. So that concludes the findings from our initial feasibility work that we did. We were able to essentially take those findings and apply for larger grants that would allow us to do a more definitive effectiveness trial to test essentially MST for those with mental illness and or co-occurring substance use disorders versus enhanced treatment as usual. And that trial is just getting underway. It was funded by the National Institute of Mental Health and allows us to do a 16-month follow-up from baseline. For that trial, we'll also be collecting additional sources of information about how the young person is doing. We collect data directly from the emerging adult participants, as well as a collateral reporter, as well as using archival records. This is also being conducted in Connecticut, and the trial started, or the work on it started April of last year. Our recruitment for that trial began December 1st, and so that is just getting underway. If we can look at the next slide. And as you could see from the work that we did, the MST teams also developed tremendous expertise in delivering substance use treatment, and so we felt that it was important to be able to address the full spectrum of emerging adults involved in the justice system that had any behavioral condition. And so we applied to NIDA, the National Institute on Drug Abuse, for a trial of MST that would focus on those who have substance use disorders, many of whom also have co-occurring mental illness. And that trial is also just getting underway. We anticipate that recruitment will start in June. It will be taking place in Tennessee and potentially in Massachusetts and Maryland as well. And that is a very similar trial in that it's a randomized control trial comparing MST to enhanced treatment as usual, and a very similar research design. And if we can show the last slide. So from our research so far, we can conclude that the adaptation of multisystemic therapy for emerging adults with serious mental health conditions successfully engages and retains young adults. The outcomes across all of the domains are in the desired direction, and that we now have 2 large-scale randomized control trials that will test the effectiveness of MST for emerging adults with behavioral health conditions, including those who present with only substance use disorders. And those trials will also look at the mechanism of action for the treatment to give us a better sense of that. And as Ashli mentioned, there is a paper at the end here that describes in detail a case study. That is the second paper listed here, and the feasibility findings for the first 32 participants was described in the first paper there. You can also email either of us with any further questions, and clearly we'll be able to follow up with any questions that you have.
Great, and that's a great segue to our question and answer section. I'm going to leave this slide up actually so that folks can take another moment to absorb the references that you mentioned and your email addresses. And I just want to let folks know that we are actually approaching the 2 o'clock hour, but if our panelists are okay with this, maybe we could stay on for just a couple more minutes to answer a couple more questions that came in. We did get quite a few questions for this webinar, so if we can't get to everybody, Please note that we have a record of your email address, and we'll be able to follow up with you after the webinar via email. So is that okay, Ashli and Maryann? Can we go ahead with this?
Absolutely.
Okay. I'm assuming the answer to this is not yet, but is there anywhere in the country where MST is being offered as a mandate of the court? And if so, is it working better or worse than where MST is being offered on a volunteer basis?
So I'll take that one. It can kind of range. So some cases are mandated to treatment, and some cases are not mandated to treatment. So we've in the programs we've had, it's been a range. So we haven't had an entire program where every case has been mandated, but we have had a range, and we don't have the numbers to show a difference, but anecdotally it's variable, and so that hasn't been kind of a key point that makes or breaks cases from an anecdotal standpoint, at least.
Okay. The other question, there's a few questions that related to the staffing requirements. What type of background is required for the therapists? What degrees? Instead of therapists, could you use a certified peer specialist? Could you speak a little bit to the staffing requirements for MST?
Yeah, and I'm sorry, I should have mentioned that. So they are typically master's level clinicians, so folks that have a clinical background. It's highly desirable if they have training already in cognitive behavioral therapy and or motivational interviewing, although that's not completely required. But they need to have pretty strong clinical skills. What we're dealing with, especially when we're talking about psychotic disorder and bipolar disorder, we're dealing with pretty significant clinical, and you're in a person's home dealing with these significant issues, and so it's a pretty strong clinical skill set is needed. So they've tended to have degrees in social work, LPCs, and MFTs, family and therapy, I think, is the marriage and family therapy. So that tends to be, but it's not a requirement. It's more about kind of what their clinical skill set is. So those are for the therapist, and then the supervisor also needs a kind of strong clinical background. And then the coaches. We often get the question, could these be former clients? Could they be peer supports specialists? And it's possible. We haven't had folks apply for the position who have been, but it would certainly be a great fit for someone who had that interest. It just hasn't been an option for us to find those folks easily in the settings where we've been.
Okay, and maybe just one more question, because I'm noting that folks are kind of falling off the webinar right now. We are a little over time. But how about costs to replicate this program? And maybe that's a future kind of a topic.
Yeah, so I'll take that one too. So we do know a lot more about the cost, in part because we know a lot about the cost for replicating standard MST. And so it is a costly program. I do want to point out that this is to avoid prison costs, so and also residential and inpatient treatment costs. And we have seen reductions in those in the samples. So the alternative is far more costly. But it is an expensive program, and so a single team is, it varies by locality, but it's somewhere in the ballpark of $500,000 for a full team to run for the year. So it is an expensive program. However, the cost for locking someone up is usually, once you avoid 2 or 3 prison sentences, you make up for that cost. But it is an expensive program compared to what is typically done, which would be like outpatient treatment, having somebody show up at a clinic.
It's probably also important to mention that both of the clinical trials will be collecting data to at least start to take a look at the cost difference, so that we can have some data to address a bit of a cost benefit analysis, although not a full trial of that, but we should have a better answer for sort of that kind of question after these 2 trials.
Great, and I'm just looking at the time and looking at our audience, and I'm thinking we should probably move on to the end. But I just wanted to thank our panelists for their time today and thank our audience for their attention and their questions. Folks that didn't get their questions answered today on the webinar, we will respond to you via email separately after this webinar. And also, I just want to let you know that our website URL is here on the screen. If you want to get recordings of this webinar and a copy of the slides, those will be available for download shortly after this webinar ends. I don't know if our panelists want to make any concluding comments.
No, thank you for
Great. Well, thank you, Maryann and Ashli, and thank you, audience. I wish you all well, and that's all for today.
Thank you very much.